which shows you what the importance of this learning is about. Right now, in the midst of the pandemic, we need to think about how we can provide safe, quality care to everyone. And this is really about making sure the workforce know what to do and how to do it as well. And so this is what's the key thing is important for us. What we have to look at is what is working well in the past and what's going to work well in the future. And we need healthcare workers to know what has happened in previous times and what can happen now. So ISQUA is really a society that we aim to inspire and get to people working forward in knowledge, networks, and voice. So what is about knowledge? I'm going to talk mainly about knowledge. But while I'm talking to you right now, we are a network, an international network across the world, and Medvarsity is part of that network. And that's why we're so proud to work with Medvarsity, because it opens us to a new way of networking with people who want to do this new ways of working. So if you had to think about what the old normal is like, it was person unfriendly. There's wide variation. We have inefficiency. We have structural inequalities. We have social determinants of health, and we have harm. And that is one of the big problems that we have to look at, is how can we make a real difference? The new normal, we like to think about a better way of going forward. Before COVID, we had these problems of person unfriendly care, of wide variation, depending where you went for care. So for a patient, it was like being in a storm. It wasn't the beauty of a perfect system. So as we go forward, we need to think really differently of how we're going to make a difference. So I'm going to spend most of my time in the next 10 to 15 minutes really about this paper that I've recently written. It's out for consultation. I've written it very in a way that people can comment. They can just go to the website and add comments. And I wrote it with Paul Batalden and Chris van Hecht. Paul Batalden is one of the founders of the quality and movement. He met with Deming in the 1980s, and he developed the call with us. So basically, what he is doing is taking the learning over the period and saying, where are we going now with them? So basically, this is what it is. We have had 3 movements in quality improvements: quality 1.0, quality 2, and quality 3.0. I think that most of us work in quality 1 or quality 2. We are now going to look at how can we get to quality 3. So what is the difference? This is the big thing that we have to look at. I think
Dr. Peter?
there are, yeah.
Dr. Peter, we would like to take a small poll at this point to understand the audience better. Yeah. For the audience, I would now be a poll would flash on your screens. I would like you to answer it. Let's wait for 10 minutes for the 10 seconds for the audience to answer the poll. Yeah. So the poll would be, I want the audience to tell us whether they have taken a similar course in healthcare quality before. You can answer in yes or no. So we're just waiting for the audience to take the poll. Yeah, so we're getting a lot of responses, yeah?
Hi.
Hello?
Hi.
Yeah, so Dr. Peter, according to the poll, around 70% of our audience has never taken a healthcare quality course before. So
Oh,
I'm sure, yeah. So it just sets the tone for the webinar. I'm sure it would be very useful to the remaining 70% who are there who have never taken a course.
that's very interesting to me, because you are all in quality one. If you've never taken a course, okay. I would say quality zero, simply, possibly. Yeah. So let's just get in. So I want to say to all of those who've never done taken a course, what I'm going to do right now is give you the opportunity to see what you can get if you do take a course. So that's the key thing that's going to happen right now. Uh, I'm just going to say, when I look at quality 1.0, which I'm going to go in the next table. I'm going to show you the next table. I'm going to spend a bit of time on this table. Quality 1.0 is the question we try to answer. Can we have thresholds for good healthcare? That is, for example, is there a standard for good healthcare? Now, I'm going to give you an example of what you do every day with quality 1. When you go to a restaurant, there are standards in the restaurant for healthy food. They can't give food that makes you sick, because then health authorities will close them down. So there's standards when you go on an airline. There are standards that we set when we buy a motor car. There's standards that we set throughout our lives. We expect things to happen. And in that one, what we would do, we'd want to have inspection to assess whether we meet the standard. Certification and guidelines. That's the step 1. It's essential. So step 1 was what happened from about 1920 to 2000. Round about then, we had accreditation and external evaluation. We still have that today. Very important. It's not one or the other. Any of these steps, they're all important. We have to set standards. Now, in terms of the quality movement, this comes from people like Joseph Duran, and I spoke about him on my last talk. Duran said you have to have planning, then you have to have controls, and then you have to have improvements. This is where we stand here. This is that you have to plan for improvement, and the controls are your standards. And then you inspect against those standards, you measure, and then what you do is you get improvements. And what often we do here in the professional bodies, we have guidelines and we expect people to follow the guidelines. However, that's not good enough. We need to go to the next level, quality 2.0. Now, what is quality 2.0? Quality 2.0 is where we have been for the last 20 years. So what happened in the last 20 years is healthcare discovered quality improvement methodology, and that is the theories of Deming. What Deming said was you have to look at 4 things. You have to look at the systems, you have to look at the variation in the systems, you have to look at the people who create the variations, and then you have to improve. This goes with what another great thinker, Don Abedian, thought. He said you have to look at systems, you have to look at the process in the systems, and that will determine your outcomes. So over the last 20 years, within healthcare, we have been looking at a systems-wide approach. How does the system work? So let me translate that into healthcare. If I come to your hospital, I would say, how does your hospital system work? If I'm a patient who has a stroke, I need about 5 or 6 systems to work simultaneously to treat me. The ED, the emergency teams, the radiology team for the CT scan, and then the neurology team in order to treat me. These are different systems that work independently and interrelatedly in the hospital system. And what we want them to do, we want them to provide good processes in order to achieve reliability. What is reliability? Reliability is the patient gets the right care the first time, every time, no matter when they come. And we know that's not what we do. It depends what time of day you come, which clinical team is on, which hospital you go to, etc. So what we've spent doing over the last 20 years in the patient safety movement, in the quality movement, is trying to understand how systems work, the complex systems, understand how the processes work within those systems to achieve reliability for the customer. And the customer could be many people. It could be the primary care physician, it's the patient, it could be the family. That's what we do. And within the hospital, if you are a physician and you send a test off to the laboratory, you become the customer for that laboratory. And we want to get performance measured well. Now, where are we in healthcare? As I said earlier, many people are sitting in the area of standards only. A lot over the last 20 years have moved to the systems approach. And where do we need to go now? And now we come to the third area, which we call co-production of health. This is where we need to work together with all the people, the producers of healthcare, that's the doctors, the nurses, and the ones who receive healthcare, the people we call patients. So the people we call patients have to work with us because they own their own health. We don't own it, they do. So we need to work with them and their families, and we call this the kinship, which means wider than the families, the communities. We have to integrate multiple knowledge systems, not only health, and we have to create a system that gives value to the customer or the patient, the person we call the patient. Okay, so now you can see the 3 different models. They are not one or the other. They're a journey that we need to go on in order to get good health care for the population. And as you're thinking of the post-pandemic situation, what we have to understand is how we move across this continuum towards co-production of health. So let me go to the next slide, which just tells you a difference between the health products and health services. And this is a bit conceptual. So for example, in the health products where we used to work out, that's like having a scan, a blood test, etc., in order to get health. However, health-related service is more about the patient or the person journey. It involves by direct or indirect involvement. It's made in the community. So for example, as we come out of COVID, how do we ensure that the public take up public health issues? How do we ensure that the public can adopt what's needed for health rather than just treating disease? So this is quite a difficult concept to get through, but it's more than just producing a blood test, a diagnosis, etc. It's more about health. So this unfortunately hasn't come out as I planned, but what it really shows is that we want to move into a situation of healthcare in which we have surrounding this person-centered care doesn't really show here. These are the domains of quality: safety, effectiveness, efficiency, timeliness, equity, and person-centered care. what happens is this person-centered care becomes orange and becomes in there. And it's surrounded by transparency. And within the center is this idea of kindness, compassion, and partnership, the essential parts of healthcare. This is what we really want to give, is kindness, compassion, and partnership. So the model of healthcare involves person-centered care surrounding all the other domains. And we add one where the person center is, we would add in ecology or the environment, safety in the environment, because that's very important. So the key message here is that in order to go to what I had previously, which is quality 3.0, we have to think differently about healthcare and how we can co-produce healthcare to go forward. And this is on person-centered care surrounding everything. And we call it kin-centered care. And kin-centered care means you involve the family, you involve the community in producing healthcare, not just receiving management of disease. So when we think of what you have to do in your learning, your learning has to give you the knowledge, and the knowledge is for you to learn how you can deliver this care in a way that is co-produced. So where you would start on your learning journeys is first understanding what would be the standards of healthcare that we have to provide. The next point would be to learn how can we improve on the standards, and quality usually go past the standards and improve on what we are doing. And the third point would really be how can we ensure that we co-produce health. So that's the journey you have to go on. And it's not, oh, we can jump to co-produce health, because you have to have the other steps in before. So imagine a future where we educate the people for quality and safety. And I think that is essential to look at. So here is the imagination that we would have. We would have leadership and change. You'll be learning about that. You're learning about how to work within teams. There you'd learn your evidence-based medicine and practice. That's what we concentrate on now. You'd have professionalism, and then you'd have scholarship as well. Surrounding all of this is this idea of systems thinking. And then on the side, I've put in the other areas: human factors and ergonomics, patient safety, person-centered care, and co-production of care. This is the new way of learning, but the reality is this is not what we received in medical school or in nursing college. We received mainly evidence-based medicine and practice, a bit of teamwork, but not really learning about leadership or systems. And we definitely didn't get all of these things in the middle of how to improve quality, how to get population and public health done, and so on.